Hello, everyone. Welcome to the weekly webinar of the International Cardio-Oncology Society. Glad you could join us today. My name is Steve Casella. I'm the Executive Director. One small change, if you are participating on the lower right side of your screen, there's a Join Rooms button. You'll want to hit that in order to participate in the chat feature today. I want to thank our sponsors for this series, Alexion and Janssen. This is a series on amyloidosis. We'll have another installment in January. And you will be able to claim CME for these two events, and I'll put information in the chat about how to do that. And we would appreciate you taking the pre-test as part of that process. So I want to welcome my co-host, regular Dan Lenahan, to give a brief introduction for today's presentation.
Thank you so much, Steve. And we're very excited to have really two of the world's experts on the treatment of amyloidosis that are going to be presenting today. The overall title is The Advancing Treatment Landscape in Amyloidosis. Are you ready? And the first speaker will be Ashutosh Weshalaker. He is a professor of medicine and hematology at the University College of London. And the second speaker will be Matthew Maurer, professor of cardiology at Columbia University Irving Medical Center. I am going to just start off by kind of laying the basic groundwork, but then I look forward to these really true international experts to enlighten us about the current treatment landscape. I am the founder and immediate past president of the International Cardio-Oncology Society and director of cardio-oncology program in CAPE. So our learning objectives for this session are to evaluate the emergent therapies for the management of AL. Number two, to evaluate the emerging therapies for the management of ATTR cardiomyopathy and ATTR polyneuropathy. And then identify patients with amyloidosis who may qualify for clinical trials. So when we think about amyloidosis, we do have to understand that this is part of a systemic disease. Now, whether you are referring there are many organs that are affected. Obviously, the heart is one of the most commonly affected, and followed by the kidney, liver, GI tract, soft tissue, and then of course the peripheral nervous or autonomic nervous system. So when we think about the multi-system involvement, as I mentioned, obviously the cardiac structure is affected, and how it is affected in the most common way is heart failure, but certainly arrhythmias, hypotension, and imaging abnormalities predominate. In terms of kidney function, ultimately there could be renal failure, but one of the earlier manifestations is proteinuria. And then neurologically, the peripheral neuropathy is potentially a prominent feature, especially in conjunction with autonomic dysfunction. And then from a GI tract, there are many different ways in which amyloidosis could affect the patient. Certainly, difficulty swallowing or dysphagia, malabsorption, a variety of changes in whether you have diarrhea or constipation, and then certainly weight loss could potentially be a very important finding in patients who have a significant GI involvement. Now, to just understand where we are in the world as it relates to cardiac amyloidosis, this is a nice figure from several years ago, but the important findings here is that what happens typically in a patient journey through amyloidosis is that for many years they're asymptomatic. There is no effect on their functional status, and then all of a sudden they become very symptomatic, and the decline can be quite rapid depending on the details of the amyloidosis involvement. But all the while that the patient is basically asymptomatic, there could be infiltration occurring. And then we have found over the course of time that cardiac biomarkers, BNP or NT-proBNP, and then troponins can be a relatively early indicator of myocardial infiltration. The problem is that we don't know how to detect the disease at an earliest stage, and that is a real challenge. And so biomarkers may be useful, but frequently by the time a patient's serum biomarkers become abnormal, the infiltration has been going on for some time. So this is still a real challenge for those of us who manage these patients. And then when we think about amyloidosis, there are many potential causes of amyloidosis. But for the most part, you really just need to know the two most common, which is AL, or what was referred to previously as primary light chain amyloidosis, and then ATTR, or transthyretin, which in the past was referred to as senile or familial transthyretin amyloidosis. The next most common is serum amyloid A, or AA amyloidosis, but still the overall probably greater than 95% of all the causes of amyloidosis make up the first two. The rest listed there are very rare causes, but nonetheless should be considered. Now, when we talk about imaging, this slide really kind of summarizes sort of the constellation of imaging characteristics, at least as it relates to cardiac involvement. So classically, the EKG will have lower voltages than expected, especially when you couple that with imaging with, for example, either echo or MRI. You'll see evidence of hypertrophy. So that mismatch between voltages, so low voltages on an EKG and a hypertrophy on an imaging, echo or MRI, should make you think of amyloidosis. And then we have been describing new patterns of strain abnormalities. And if we look at the bullseye description of the echo strain imaging, you can see that there's this pattern where the imaging in the apex is basically normal in terms of strain, and then up near the base is very abnormal. And this pattern is referred to as apical sparing, or some people have said cherry on top because it sort of looks like the red part in the middle. But nonetheless, that could potentially indicate, certainly a cardiomyopathy, but specifically maybe amyloidosis infiltration. And then this middle panel on the bottom is a pyrophosphate scan where you see significant uptake in the heart. And you know that this is a pyrophosphate scan because of the arthritis here in the shoulder. And that's it's a bone scan, basically. And then cardiac MRI, this is a classic image actually of AL amyloidosis because of diffuse subendocardial hyperenhancement. That is sort of a classic image for MRI in regards to AL. So I won't go through this in all detail, but really to just talk to you in general about how we make the diagnosis. And there are a number of blood tests, urinary tests, imaging, and then other tests that may be important. And these are just some suggested things. Very commonly, and I would say in most patients, that they're going to get more than one test for sure, because one test may be only partially abnormal, where another one may be more convincing. So it's not surprising that you would get a number of tests to really define the extent of amyloidosis. And then in terms of biomarkers, this is a very nice review from about a year ago, just summarizing what we know about biomarkers in regards to making the diagnosis of amyloidosis. So I won't go through all these in detail, and we actually did a webinar just recently highlighting biomarkers in amyloidosis. I will emphasize that it's one thing to make the diagnosis, and then the question is are biomarkers useful in terms of monitoring disease progression? And so this is a report just highlighting that the common biomarkers that are used, NT-proBNP and troponin, may be very useful for disease monitoring, but we still don't have a lot of good data in that regard. We're still trying to figure out how do we show benefit in our treatment. And then lastly, it's not uncommon at all that we would need to do a biopsy to confirm the diagnosis. And whether you do a fat pad biopsy or a renal biopsy or a cardiac biopsy, these are all choices to be made. And depending on your institution and expertise, then you may choose one or another. But in the end, it is very valuable and usually required to do a biopsy and look at the actual fibrils to confirm the type that has led to the involvement. And at this time, I would hand over the presentation to Dr. Weschelacker, who is going to tell us about the current treatment of AL.
Thank you for your kind invitation to this webinar today to talk about AL and ATTR amyloidosis. And thanks to Dan for the wonderful introduction to the topic. My remit today is to raise what the current questions are in AL amyloidosis and then discuss what new treatments are available and how they may address these current questions in AL amyloidosis. So as you have already heard from Dan, amyloidosis is a complex process. It involves misfolding of proteins. We are talking about AL amyloidosis in this talk. So we have got plasma cell dyscrasia, producing excess light chains. These proteins will misfold, bind to glycosaminoglycans and form amyloid fibrils. AL amyloidosis has always been considered to be a disease with poor prognosis. This is an EMN study looking at patients with AL amyloidosis from 2004 to 2010. And there has been some improvement in survival for patients with cardiac amyloidosis, but overall, our progress has been fairly slow and not that encouraging. So what are the problems that we face in daily practice? In fact, these are the questions that we have. We have problems with diagnosis. There's a lack of recognition that amyloidosis is not as rare as we think. There's a lack of a blood test to identify MGUS patients who are at risk of amyloidosis. There's a lack of standardized criteria that we need to follow up MGUS patients to detect amyloid early. Once we've diagnosed amyloidosis, these patients are often polysymptomatic, where we don't have any studies to tell us what optimal supportive care to give them. We need better prognostic stratification. We are moving in that direction. Daratumumab with bortezomib, cyclophosphamide, and dexamethasone is the currently licensed treatment. Is that we should for every patient, or should we think of different treatments for different patients? And then how long should we give these treatments? And how frequently should we change therapies? And then finally, when we are following up these patients, we have to assess whether they have responded to therapy, how much have they responded to therapy, and has this therapy really been beneficial in achieving an organ response, hopefully to translate into improved quality of life and survival. And lots of different problems in different areas of amyloidosis. The first one being lack of recognition. Symptoms are common, disease is rare, and there is no single diagnostic tests. These are two separate studies showing that patients have had a number of different encounters with healthcare professionals, or hospitals indeed, before diagnosis is made in both AL and ATTR amyloidosis. What can we do to address this problem? To me, the answer is very simple. It is patient education. The better we can educate our patients and our physicians to the fact that this diagnosis is not that rare, we will be able to diagnose it early and better. We have talked about lack of recognition of MGUS, which may progress to amyloidosis. We are getting there to a degree. we now have studies which can look at gene expression profiling. And this is one such study where they looked at gene expression profiling in AL amyloidosis and MGUS. And you can see there is a significant difference between the expression profile for genes in AL plasma cells versus MGUS plasma cells. And we may consider using this more widely. Genes such as those associated with glycosylation are much highly expressed in AL compared to genes associated with cell multiplication, such as phosphorylation and ribosome biogenesis, which are more expressed in the malignant plasma cells or multiple myeloma. We've got new methods of detecting light chains in the blood, one of which is mass spectrometry. And using mass spectrometry, we can detect these nice light chain peaks in the blood. But in AL amyloidosis, we detect what's described as glycosylation, something that we found out on the transcriptomal studies that plasma cells show excess transcriptomal profiling. We can see that in the blood with light chains being glycosylated. And more recently, our Italian colleagues identified a point mutation in the kappa gene, showing that patients who had this point mutation were at a much higher risk of glycosylation. So we could use these tests to tell us which MGUS patients are at risk of developing amyloidosis. And then we have to think about red flags that physicians, hematologists, general practitioners, or other healthcare professionals have in following up MGUS patients. Proteinuria should not happen in MGUS. Think about a gammopathy-related renal disease. Unexplained periorbital bruising, of course, is very characteristic of amyloidosis, but happens only in 25% of patients. Of course, heart failure with preserved ejection fraction. I won't talk about this in more detail as we've got a further talk coming. And then evidence of LVH and ECG with lower normal voltages. Unexplained fluid retention in patients with myeloma after starting chemotherapy, a combination of peripheral and autonomic neuropathy, should all be signs that the patient is likely to develop amyloidosis. Once we've diagnosed amyloid, we have to do two different things. One is to detect the end organ damage, which is the cardiac biomarker staging. We can detect the renal damage with renal staging. We can use a variety of tests, such as functional and imaging tests, to detect how significant the amyloid damage is. And then we look at the bone marrow to figure out what is actually going on in the bone marrow in terms of the percentage infiltration, the cytogenetic changes, and the gene expression profiling changes, which will all tell us to what degree this patient is at risk of developing systemic amyloidosis and what will happen to them after they're treated. Once patients are started on treatment, we can look at time to response, the depth of response achieved, and impact of early progression. Recently, we've had studies from our center and from other centers which have looked at flow cytometry in the bone marrow. And what we can show is that patients who have more than 10% abnormal bone marrow plasma cells tend to have much worse outcomes. Similarly, our Spanish colleagues showed that patients who have a phenotype in the bone marrow which is similar to gammopathy have a median survival of over 3 years compared to patients who have an intermediate phenotype where the median survival is only 11 months, and those who look more like myeloma have only a median survival of 3 months. Even simple bone marrow trophine biopsies can help us to differentiate this. Patients who have more than 20% plasma cells in the bone marrow tend to have much worse outcomes. This is with chemotherapy, this is with stem cell transplantation, and this is data from the Mayo Clinic. Patients will have cytogenetic abnormalities in amyloidosis, and patients who have chromosomal abnormalities such as T1114 translocation tend to have poorer prognosis in amyloidosis compared to patients who don't have these cytogenetic abnormalities. One of the key challenges in amyloidosis is to assess the response to therapy. We have used biomarkers for many years, and they are one of the best ways of assessing response in amyloid patients. We have had a binary system, response, no response, based on whether the NT-proBNP levels had decreased by more than 350 nanograms per liter and 300 and 30%. But more recently, we've published this in the Journal of Clinical Oncology with colleagues around the world, showing that we can grade cardiac responses. Patients who normalize their biomarkers are called as cardiac CR. Patients who have a 50% reduction, 31 to 60% reduction are called as a PR, and those who have a less than 30% reduction as a non-responders. And there is a stark difference in the prognosis of cardiac complete responders versus cardiac non-responders. What is also striking here is that the number of good cardiac responders, the VGPRs and the CRs, as you can see, go up from about 10% to nearly 40-45% by 2 years. So there are responses, they are cumulative, but they are slow. We reported this some years ago now that longitudinal strain is important in both diagnosis of amyloidosis and baseline. Patients who have poor longitudinal strain have poor outcomes. Patients who have good longitudinal strain have good outcomes. And we can use this to risk stratify the patients in addition to the standard baseline biomarker-based stratification system. And we can also use it to assess response to therapy. A functional test is very helpful. We use a simple 6-minute walk test, which most cardiologists are familiar with. Patients with advanced stage cardiac disease has had worse 6-minute walk scores compared to patients with early stage cardiac disease. And patients who walked well, more than 300 meters, had significantly better outcomes compared to patients who walked less than 300 meters. Similarly, patients who were unable to attempt the cardiac walk test had markedly poor outcomes compared to patients who were able to do the 6-minute walk test. While this is a simple marker, it has to be done well to be reproducible. About 70% of patients with amyloidosis have renal involvement. Our focus has always been on the heart, but patients who present with kidney disease, particularly those who have a low GFR and who have significant proteinuria, so-called stage 3 kidney disease, 3/4 of those patients will be on dialysis within 2 years, and there is about 5 to 10% risk of dialysis ongoing thereafter. And we reported something very similar when we published this from the series of Amyloid Center. And therefore, renal involvement has a major impact on the quality of life of these patients, even though it may often not have such a direct impact on the patient's survival. Moving on to treatment for amyloidosis, which is the second part of my talk. The treatment algorithms have been around for a long time. This was one published in Blood by Giovanni Palladini and Giampaolo Mellini, showing that patients can be risk stratified into 3 different groups. And we published guidelines from the International Society of Amyloidosis, which are now out just recently, telling us how to treat patients both with transplant and non-transplant-based approaches. This risk stratification has been pretty standard for a long time, and we haven't really changed this risk stratification substantially over the last few years. The standard treatment for most patients is combination chemotherapy with cyclophosphamide, bortezomib, dexamethasone, and based on the results of the Andromeda study, daratumumab should be added. A small number of patients would be suitable for an autologous stem cell transplant. One of the key factors in assessing response to therapy is how fast these patients respond. And if the patients don't achieve our goal of treatment, which is a complete response or a near complete response, we need to change therapies. We looked at this in our series of about 900 patients treated with a bortezomib-based regimen at baseline, and we came up with a risk scoring system. And the risk scoring was very simple. Patients had to have a DFLC score, which is the difference between the involved and the uninvolved light chain at baseline, more or less than 400 milligrams per liter. Patients who had partial response or less was another point in the score. And when we risk stratify, patients who score 0, 66% of these patients went on to improve their response even if they hadn't responded at 1 month. Patients who scored 2, which means that they had a DFLC of more than 400, and they hadn't really achieved a PR or a 50% light chain reduction at 1 month, only 5% of these patients went on to have an improved response. And therefore, based on this, what we have come up with an algorithm is that if you have a DFLC of more than 400 and you have less than a PR, you should switch treatment as early as 1 month. On the other hand, if you achieve a VGPR, irrespective of the DFLC, carry on with the same treatment for longer. And then for the other two groups, where you are seeing high DFLC, but either a PR or a low DFLC and less than a PR, you can continue with treatment for at least 1 or 2 more cycles, see if the response deepens. If it deepens, carry on. If it doesn't, then you switch treatments to a different regimen. What about autologous stem cell transplantation? It is one of the most controversial things in amyloidosis. It's also one of the very good treatments in amyloidosis. We looked at this recently because of the good responses that we were able to achieve with bortezomib-based regimen. And in our hands, in a matched cohort, patients treated with Velcade versus transplantation, as long as their organ dysfunction was fairly similar, appeared to have similar overall survival. Colleagues from Boston presented this data at the International Society of Amyloidosis meeting, showing that patients who achieve a complete response with autologous transplantation, the duration of complete response is prolonged, more than 12 years. This is fairly unprecedented, and we often don't see this with chemotherapy. So yes, although we can't show a substantial difference in retrospective studies, The duration of CR is indeed impressive, and there is a role for transplantation in amyloidosis. What's new here? The melphalan, which is the conditioning regimen used for transplant, is the key reason for morbidity and mortality. We got asked the question whether we could do a transplant with a lower risk, and we used radiation for stem cell transplant conditioning without any chemotherapy. We radiolabeled an antibody to CD66, which is a pan-leukocyte marker. Patients were given this dose about 14 days prior to their stem cells. All patients engrafted, and what we found was that transplant was relatively an easy procedure with no serious mucositis. Very few patients developed significant temperatures, CRP remained low, and patients were able to have excellent oral nutrition with no significant fatigue. In this dose escalation study, we achieved about a third of the patients achieved a complete response, another third of the patients achieved a VGPR, and some of these responses have been fairly long sustained. Of course, the key study which has changed our treatment with amyloidosis and led to licensing of the first ever treatment for amyloidosis was the Andromeda study, which most of you have seen many times. This is the long-term follow-up presented by Dr. Comenzo last year, showing that patients who were treated with Dara-VCD arm at a median follow-up of 25 months, 60% of these patients remained in a CR compared to just about 20% of patients with VCD. Safety follow-up showed that there was no significant difference in the safety profile of the two regimens, and the AEs were reasonably comparable. What was quite striking was that at an 18-month cutoff, 50% of the patients had achieved a cardiac and a renal response compared to about a quarter of patients with just VCD, which is what we normally see. About 50% of patients with AL amyloidosis will have a translocation of chromosome T1114. Venetoclax is a drug which can treat patients with 1114 translocations by impacting their cyclin D1 pathway. We did this retrospective study of patients treated with venetoclax and AL amyloidosis, showing that 80% of patients will achieve a complete remission with venetoclax compared to those who don't have the translocation. What was also quite striking was that patients who had a T1114 and were treated with venetoclax, there was a significant benefit in terms of survival compared to those who did not. Whilst there are no prospective studies of this agent, and we do hope we may get prospective studies in coming years, this is certainly an attractive treatment for patients with AL amyloidosis. Belantamab mafodotin is a monoclonal antibody conjugated to BCMA, and it is a BCMA conjugated toxin, and we have shown about 60% to 65% good responses in multiply relapsed patients, and a very similar study in myeloma patients was related by colleagues in the US. Active immunotherapy is very important in treatment of multiple myeloma, and this study presented at the International Society of Amyloidosis showed the first ever data for CAR T cells, chimeric antigen receptor modified T cells and amyloidosis, showing that it is deliverable, and we see deep responses as well. But the key is to get organ responses and get them rapid. And for this, we need to use agents which can remove amyloid. We had a program with antibodies to SAP. This is not progressing any further because we ran into some toxicity problems. There are two programs which are going ahead, and we'll talk about this in a minute. And there are some other agents which are in very early phase of preclinical development that we shall see as well. So bertamimab, that's been the longest studied antibody at the moment for AL amyloidosis, on EOD001, targets misfolded light chains. In the phase 1/2 study, 50 to 60% of the patients showed cardiac and renal responses, which appeared to be extremely promising. This then went on to have a phase 3 study, which was the VITAL study, and analysis of data from the VITAL study showed that patients with advanced cardiac disease, Mayo stage 4 amyloidosis, appear to have a survival benefit. Currently, the AFFIRM clinical trial is recruiting patients with newly diagnosed stage 4 cardiac amyloidosis for randomization with bertamimab versus placebo, and chemotherapy being standard of care. This is the data which prompted the study, showing that patients who were treated with bertamimab plus standard of care had a better survival on the post-hoc analysis of the VITAL data, and there appeared to be significantly less decline in the quality of life in the bertamimab group compared to the patients who were treated with placebo. KL101 is another antibody which targets misfolded kappa and lambda light chains. It has been through phase 1 and small phase 2 clinical studies. And again, given as a single dose in the phase 1 clinical trial, 60% of patients showed cardiac responses, including responses in the global longitudinal strain. We saw normally patients not on any monoclonal antibody treatment, strain responses can take up to 1 year to be apparent. Here we could see that some patients showed improvement in GLS as early as 12 weeks. These are the 2 phase 3 studies that are ongoing with KL101, the 301 and the 302 studies for Mayo stage 3B, the very advanced cardiac disease, and Mayo stage 3A, newly diagnosed but still advanced cardiac disease, randomization with KL101 versus placebo in both compared and antiplasma cell therapy being standard of care. The overall survival is the primary endpoint of this study. AT01 is a humanized IgG fusion with a small pan-reactive peptide. This has been shown to image amyloid deposits very nicely in both animal models and humans. This has also been studied in mouse model of amyloidosis, showing that in AA amyloid mouse model, there is significantly better clearance of amyloid in mice treated with AT02 compared to control mice. And in human models, there appears to be better clearance of the lambda light chains. This is now progressing to phase 1 clinical trial. There is a phase 1 healthy volunteer study, which will then go on to a phase 1 dose ascending study in patients with systemic amyloidosis. AT03 is another very interesting molecule. This is very similar to the anti-SAP approach that we had, but the difference being that the SAP molecule is conjugated with FC fusion proteins. And in a mouse model of AA amyloidosis, there appeared to be significant clearance of amyloid deposits in mice treated with this AT03 fusion protein compared to control mice. And again, a biodistribution study is ongoing. We look forward to the results of this in the near future. So to conclude, we have a number of different problems that I outlined before. We are having some solutions. We need to make amyloid awareness a critical part of our education goals. There are new genomic and proteomic markers that are available. We need to start using them more widely. We need studies for amyloid supportive care, and we need more studies with novel therapies, both for the plasma cell dyscrasia and also those that accelerate amyloid removal. There are phase 3 studies ongoing for cardiac amyloid, but we need studies for patients with non-cardiac amyloid as well. We need better assessment techniques. Imaging is improving, but we need to understand how to integrate imaging with our response assessment. And of course, we have got a number of different ways of assessing response to therapy, but we need to integrate this with in clinical trials and prospective studies. So yes, a lot is happening in amyloidosis, but a lot still needs to be done in AL amyloidosis, as 50% of the patients still present with advanced disease, and we still have a 20 to 30% early mortality. Thank you.
Fantastic. That was really a great overview of a very complex and exciting field. So thank you so much. Ashutosh, there are many questions that could come from all this, but first off, what treatment do you consider the best initial treatment with a new diagnosis of AL? And then if that includes daratumumab, which I think it does based on your slides, that what if a place is not able to get daratumumab? What would be the best initial therapy?
So thank you, Dan. I think bortezomib-based regimens still remain the standard of care. For me, Cy/Bo/D is the frontline treatment for amyloidosis, and we certainly use that in the UK. We don't have access to frontline daratumumab. Where Dara is available, then Dara-Cy/Bo/D is certainly the regimen of choice. Transplantation remains an important treatment, particularly in resource-constrained settings where you can't give Dara for a long time or where Dara is not accessible or available.
And then how this you also address this at sort of multiple places in your talk, but this is the other major question that certainly I would have. How often do you follow a patient with, say, biomarkers, whatever the biomarkers you're used to following? What interval do you think they need to be done?
I think biomarkers are critical, when you are deciding on a change of therapy or you're assessing whether the organ has responded, we tend to measure the patient is on therapy, but we find that they often are very unstable during early part of treatment as patients are fluid overloaded. So the real role of biomarker comes in once the chemotherapy has been completed, patient has achieved a good response, and then you want to assess whether their heart is getting better or not. That's when the NT-proBNP really comes on its own. And we would normally follow it up every 1 to 2 months after completion of treatment, and then every 3 to 6 months thereafter, so that it can be monitored fairly regularly.
And then in terms of your hematologic-based biomarkers, you know, the serum-free light chains or whatever other monoclonal protein measurements that you're making, how often do you do those during therapy?
So that's very different because that is critical in deciding what do we do with treatment. And as I showed in that algorithm, we often need to make decisions about treatment changes very early. So we tend to measure serum-free light chains every week or even every other week in the first 2 months of therapy, which allow us to make decisions about switching treatments. Once we are very clear that the patient is responding, we can then move on to measuring them once a month. And then following completion of therapy, we measure them usually every 2 to 4 months, depending on the depth of response achieved.
Super. Thank you so much. Really, you covered a huge amount of territory, and it's going to take us a little while to chew on all that, I think. But let me move on to Dr. Maurer, who is going to tell us about, thank you very much, tell us about ATTR amyloidosis.
Thanks all. Hope you can see my slides. It's a pleasure to be with everybody today. So therapies for transthyretin and amyloidosis have really emerged from elucidation of the underlying biology. We know transthyretin is a small tetrameric protein of 127 amino acids that's produced in the liver, as shown here, that folds into a tetramer. And in the setting of instability due to variants in the TTR protein or with aging, can become unstable, dissociate into oligomers or monomers that can deposit in various tissues, particularly the heart and the nerves. And with the understanding of this biology, emerging therapies have come to the forefront. And those include so-called gene silencing or knockdown therapies, including antisense, small interfering RNA, and potentially even CRISPR-based therapies soon in the future. There are TTR stabilizers, tafamidis, the only one approved, but diflunisal off-label and acoramidis in development. And then there are also, as Dr. Wexler was pointing out, anti-amyloid therapies emerging in this space for TTR amyloid as well. The current treatment landscape is shown here, whether you have a variant or wild type disease, a cardiomyopathy or a neuropathy. Tafamidis is often available in various locations, though I think for most clinicians, those patients with a certainly variant disease who have only a neuropathy or a cardiomyopathy, many of us favor a silencer-based treatment approaches. And the hope is that there'll be an opportunity for many therapies to be leveraged in the future. So these are some of the, I think, issues that are being addressed by ongoing clinical trials. While there are effective therapies that significantly reduce morbidity, mortality, and the functional decline, there is disease progression despite the application of these agents. There is, as you'll see, significant residual mortality. Many patients still experience, unfortunately, progressive functional declines, and there's a deterioration in one's health status. And certainly patients who are often identified, unfortunately, still with an advanced phenotype derive a lot less benefit from approved therapies. And as we heard before, there's an urgent need to improve awareness, identify subjects earlier, maybe develop better oral stabilizers, that's a question mark, and obviously gene silencing therapy and antifibrillar therapy have roles we hope to play. So these are the data from the ATTR ACT trial showing that tafamidis was highly effective at reducing morbidity and mortality. But as I highlight here, there's still a residual mortality of 30% at 30 months. And so definitely an unmet need in this particular regard. And tafamidis, as we know from the original trial, did slow the decline in the 6-minute hall walk, and the decline in health status as measured by the KCCQ overall summary score. But patients, even on therapy, still on average continue to progress. And so most patients ideally want to stay the same or feel better. And in the trial, we highlighted that across 11 pre-specified subgroups, tafamidis was highly effective, but there was one subgroup, those with NYHA class 3 symptoms, more advanced disease, who lived longer on tafamidis therapy, but suffered because of their advanced phenotype, more cardiovascular hospitalizations. So again, better therapies for those with more advanced phenotypes is certainly needed. And so I think no talk about amyloid would should be given without emphasizing the need for early diagnosis. I think you need to put amyloid on your differential diagnosis in anyone who has an increased wall thickness with any one of these variables, and these are quite general. Someone who's elderly, who has a concomitant aortic stenosis, someone whose blood pressure is declining over time, has a peripheral neuropathy or proteinuria, a history of orthopedic manifestations, be it lumbar spinal stenosis, bilateral carpal tunnel syndrome, or ruptured biceps tendon, discordance, as we heard, between the wall thickness and the EKG, or the presence of pseudoinfarcts, or an individual has a family history that's suggestive of hereditary disease, or any other imaging findings, including echo, apical sparing, we heard, and or subendocardial, or any type of enhancement on MRI. We've been incredibly focused on this in our laboratory, and I'm privileged to work with my colleague Rick Ruberg. This is a study that's being conducted in New York, Boston, and now in New Haven, called SCAN-NP, in which the overall goal is to change the approach, trying to facilitate earlier diagnosis, particularly in a population of individuals who are highly susceptible to a variant TTR. Those are individuals who have West African ancestry or Black or Hispanic, particularly Hispanics from the Caribbean, and they get, if they have heart failure with an increased wall thickness, phenotyping, and we're planning to enroll 800 participants, and we're more than halfway done in this particular screening study. These are the phase 3 trials that have been executed to date or underway, and we'll talk about each of them. There's the acoramidis or ATTRibute-CM studying acoramidis, oral stabilizer, and the Part A study had a readout in which unfortunately it was negative with regard to the change in 6-minute hall walk at 12 months, but we're quite hopeful for the Part B readout, which is harder endpoints. Patisiran was studied in the Apollo B trial for cardiomyopathy alone, and that trial read out and had favorable primary and key secondary endpoints that were both met. And then vutrisiran is being studied in the Helios B trial, a sub-Q silencer, in which the expectation is that trial will report out in mid-2024, fully enrolled. Plenitursin is being studied in the CardioTransform trial, which is now the largest trial to date, that's enrolling 1,400 individuals, with expectations that the trial may read out sometime in 2025. And we saw exciting data presented by Julian Gilmore recently at the AHA about CRISPR-based therapy, and we're noting the success of the phase 1 trial and hoping for a phase 3 trial later in 2023. So I will remind everyone that disease progression in certainly TTR, but other forms of amyloid, is not linear. This is a chart that we drew years ago in which you can see myocardial infiltration occurring very early with, most importantly, I think from the patient's perspective, a pretty stable functional status and quality of life until you reach what I consider to be the slippery slope. The slippery slope is shown here in blue, and those are many of the patients that we enrolled about a decade ago in the ATTR-ACT trial. And we are clearly identifying people much earlier in the course of the illness, which I think is a great thing. Drugs work better early in the course of the illness, but poses a significant dilemma for the development of new therapies because the event rate is quite a bit reduced. These are data, for example, from our center just showing survival differences over different eras, and you can see marked improvements in survival over time in ATTR amyloidosis. And if you're using an event-driven trial, that confounds the ability to bring drugs to market, so to speak, with effective phase 3 trials. So in the ATTRibute-CM trial, unfortunately, acoramidis, looking at a Part A endpoint of a change in 6-minute hall walk at 1 year did not meet its primary endpoint, the p-value shown here. And what was most surprising is while acoramidis, if you will, appeared to really, compared to historical controls or to the ATTR ACT data, slow the decline in 6-minute hall walk, compared to the group that they recruited on placebo, there was no meaningful change. And I think this is reflective of the fact that they probably recruited a population that was much earlier in the course of the illness without much significant decline in at least 6-minute hall walk over this time period. And notably, they did report out that there were nominal p-values for several relevant, if you will, biomarkers, including the change in NT-proBNP, the Kansas City Cardiomyopathy Questionnaire, and indicating target drug engagement, TTR concentrations went up. And they also noted that there were 27% fewer emergent adverse events that led to death. Obviously, I don't know who's on therapy or not. And so we all anxiously await the readout early in 2023 or mid-2023 about the acoramidis trial with regard to the hard endpoints. The therapeutic hypothesis behind silencing therapy is shown here, where we're either using small interfering RNA, antisense, or CRISPR. As we said, there's a production of a mutant or wild type protein that becomes unstable, deposits in the organ, and causes the phenotype. And by blocking production of the precursor protein, which has been effective in all other forms of amyloid, as we saw, especially with AL amyloid knocking down or reducing the production of light chains, we hope that there'll be not only reduction of the unstable circulating tetramers, which happens, but prevention of organ deposition, and maybe even, besides stabilization, reversal of the phenotype. And so Apollo B data that I mentioned reported out. The primary endpoint was a change in 6-minute hall walk at a year's time. You can see in the placebo group shown in red, there was about a 21-meter decline. Those on a patisiran had relatively stable 6-minute hall walks, and the difference was 15 meters, which was statistically significant at 1 year. And similarly, the key secondary endpoint was the change in Kansas City Cardiomyopathy Questionnaire. The placebo group had a decline, the patisiran group was stable, and the mean least square difference was 3.7 units on the overall KCCQ score, with again a statistically significant result. Similarly, we recently reported echocardiographic findings from this trial, and you can see here is global longitudinal strain with worsening in the placebo arm compared to the patisiran arm, LV mass stable with progression in the placebo arm, a change in end diastolic volume with a smaller heart in those on patisiran, placebo, indicating less ventricular capacitance, and that's associated with a decline in the cardiac output. Mean wall thickness didn't really meet statistical significance, nor did relative wall thickness, but several echocardiographic parameters that suggested a favorable change over a relatively short time period. And gene editing is really, I think, one of the most exciting things on the block. These are fantastic data from the NAC presented by Julian Gilmore in the New England Journal last year, and an update about the cardiac data. This is a amazing technique leveraging CRISPR-Cas9, in which a single lipid nanoparticle that has a TTR-specific guide, bringing, if you will, the CRISPR-Cas9 system to the right spot in the genome to, after it's taken up by hepatocytes because of the lipid nanoparticle, essentially permanently decreasing the production at the genomic level of transthyretin. And so TTR levels in the original polyneuropathy group with various dosages had significant reductions by 28 days. And there's recent reports now that even in cardiomyopathy patients, this was well tolerated. The reductions with 0.7 milligrams were sustained out to several months. Additionally, there's the emergence of anti-amyloid therapies, which have the great hope of ameliorating pre-existing amyloid in various organs in individuals who unfortunately could be diagnosed late. There's a great deal of activity. You've heard about some of the AL compounds in this space. This is the Novo Nordisk, formerly the Prothena compound, PRX-004, that they acquired. They've initiated a phase 2 study already. There's in the TTR space, Neurimmune has a compound, and we heard about AT03, which targets all forms of amyloid, both AL and ATTR, being brought to bear by company Atralis. So the one that's furthest along in this space is, again, formerly PRX-004, studied in a phase 1 trial, now called NNC-6019. This is a humanized monoclonal antibody that targets an epitope that is exposed only on monomeric misfolded TTR in aggregated forms, but hidden in the native TTR tetramers. And the theory here is through antibody-mediated activation and phagocytosis, these amyloid fibrils could potentially be degraded inside tissues, and obviously those that are in the serum and plasma could be also addressed through this antibody-mediated mechanism. So I would just say that there's a kind of a rapidly evolving landscape and timeline in the generation of evidence. Going back to the original tafamidis polyneuropathy trial in 2011, we've moved obviously to start the ATTR ACT trial, which reported results out in 2018. We've moved to an ability to diagnose patients earlier at point of care with a non-biopsy approach by the seminal paper by Julian Gilmore and colleagues. And we've had now at least one approved therapy for cardiomyopathy. We have other therapies for neuropathy that we're quite excited about and look like they're quite active in this particular space. And so despite the pandemic, we've been able to continue drug development. And I think it's a testament to not only the investigators, the scientists, but the patients and their commitment to this field. So I'd say that the key messages I want people to realize is that there have been emerging therapies, and that really grows out of an experience with regard to our basic science colleagues really elucidating the biology of the disease very effectively. Current therapies are quite effective at reducing mortality and morbidity, but there's still a high residual event rate, which I think we all believe represents an unmet clinical need. And early identification, I still believe, is really one of the most important things we can do to leverage emerging therapies. Tafamidis as a therapy works fantastically when given early. And so the full potential of therapies won't be realized until we really identify people early in the course. And I think while we're very successful in this field, it has made, because of the declining event rate, the development of new therapies slightly more complicated with larger trials, similar to what we see in more general heart failure studies. Who knew we were going to conduct 1,400 person trials in amyloidosis, but we are, and we're succeeding. And that makes the whole process, I think, a little more complicated. So again, thanks for your time and attention.
Thank you so much, Dr. Morrow. That is, again, really a tremendous overview of what is a very exciting space. So I think seeing how much development there is in AL, followed by how much development there is in ATTR is really exciting. So, and I thank you for sort of leading the field in that way for many years. If I could go back to some basic question, for example, you know, I showed that original figure about, you know, and I think you probably were the nidus of that figure back many years ago. And then you showed the more recent figure that was a lot more complex that was published last year. The whole idea of biomarkers and what their utility may be for the treatment of ATTR, you know, what is your thought on that? And then, you know, in a second part of that question would be, you know, you did show one slide where the TTR level could be used as a marker of drug efficacy, at least in those people who are not getting silencers. So what is your take on that whole picture, and where are we right now in regards to that?
Yeah, I think it's a great question. So obviously there are two main biomarker solely based staging systems, one developed by Martha Grogan at the Mayo, which involves an NT-proBNP of 3,000 picograms per ml and a troponin T of above 0.05, and one developed by the NAC and Julian and colleagues, which uses the same NT-proBNP, but leverages estimated GFR above or below 45. And those staging systems do very well at prognosticating patients at baseline. There's recent data published by the NAC showing that they're quite useful in follow-up as well over time. And so patients, God forbid, who progress from one stage to another, you can imagine do worse. NT-proBNP changes of 500 picograms, 1,000 or 1,500 have higher and higher hazard ratios. So certainly something that we all follow. We colloquially developed the staging system with Wayne Levy and Richard Cheng. We call the Columbia, which it uses the NT-proBNP or the NAC or the Mayo. We added NYHA class and daily use of diuretics, the furosemide equivalents, and that has as well, I think, a little bit more refined prognostic significance. So we definitely follow patients in that regard. What do we do? I think nowadays, interestingly, we're applying a lot more SGLT2 antagonists to patients who seem to progress, and we've had an open label pilot study we're almost completed here that shows pretty amazing effects of the drug. So there are some basic cardiac things to be done, and the hope is as these new therapies get developed, we'll all be in this enviable position of trying to figure out when someone is progressing and how to switch someone. That'll hopefully be data-based. With regards to your question about prealbumin or TTR levels, they go up within, usually 28 days of starting a stabilizer. They go up by quite a bit, usually about 30 to 50%. They go up more in women and more in variant patients because they start lower. Having said all that, we published our data. I know Rodney Falk did as well. In our data set, that rise does not seem to have additive prognostic value on top of the basic biomarkers. So it's nice to show a patient that your stabilizer is working, diflunisal or tafamidis, and they do want that evidence, but I'm not sure it's going to turn out to be that additive as a clinical biomarker to follow over time. And as you said, it gets complicated. If you start a silencer, then the levels go undetectable, and so there's really not much to follow anymore.
So then, where do you see imaging fit in terms of following patients as they're undergoing therapy? Because I think just like any patient would want to know, is this therapy working? And I guess you could say that if they came for follow-up, then it's probably, at least there's an encouraging sign that it's working. But it's always nice to be able to do some sort of test that says, yeah, this therapy is doing the right thing.
Yeah, I completely agree. I think imaging is going to play a large role. If I had to bet, I would say more specific and accurate imaging that can quantify amyloid load or a surrogate of that is going to be the thing to follow. So you could advocate for an echo, but I mean, basic things like wall thickness, as we know, have high variability and are kind of very useless, quite frankly. Strain may be useful. Having said all that, it was circumferential strain in the ATTR ACT trial that changed, and that's not clinically being measured by everyone. Global longitudinal strain didn't seem to play a big role. Basically, one of the big parameters on echo I encourage you to follow is the stroke volume. That's what really seems to be a big differentiator. But I think MRI, as groups are looking at, and ECV could play a role with reasonable frequency. I don't think you're going to do this every month or every 6 months, but maybe once a year. We actually just started with Jonathan Wall's compound, a new he has obviously a peptide labeled with I-124 adazulamide, and this particular agent can do a PET scan like we do in sarcoidosis, image amyloid in almost every organ in the body, and probably can get quantification. So I think that'll probably be something that'll be the future. I used to be a little nihilistic about the cost of imaging, but if we're going to spend $250,000 or $500,000 on a drug a year, that we probably can spend a few $1,000s to figure out if it's working. But I think the MRIs and the PET scans, obviously CT scan and quantification using scintigraphy also could play a much more simpler and larger role as that becomes to fruition.
Yeah, I think that, I appreciate your comments on the more advanced imaging, because I think, there certainly may be something there, and it's going to take, some definitive research to kind of move that forward. The sort of general implication that you could do a pyrophosphate scan periodically and shows some benefit, for example, at least in the US. I mean, I know they use DPD in Europe or in the UK, but you could use those scans to sort of show some general improvement. I haven't really found that to be the case, but I know you've published on this type of question before.
Yeah.
So
Yeah, we didn't find it to be the case years ago either. There's this very provocative data that's now being presented in the Helios, if you will, a trial, and others. Apollo B has it, in which grade 3 scans, even grade 2 scans, are becoming grade 1 or 0 scans. I think we should, view that with real interest and learn a lot more. We don't even know what PYP or DBD is binding to, and so, a little unelegant. We have a patient whose scan dramatically improved, and his other imaging techniques, echo, actually, the John Wall compound didn't change or are still very, very positive. So, yeah, I agree. I think quantification of PYP may show some changes, but we're going to also be needing to figure out if it really reflects amyloid load as much as we think some of these other imaging techniques do. A lot of questions to be answered.
super. Wow, this has really been a great session, and thank you so much, Matt, for really an expert overview. And we're really looking forward to all the stuff you're working on, and we'll keep you on our short list in terms of monitoring whatever's going on in the world of amyloidosis. So thank you very much.